Welcome to another live broadcast of the Nursing Home Podcast, the podcast that you've learned to follow and trust, where we discuss and really dig in to the issues, the challenges, and the unique aspects of the nursing home industry. In today's podcast, we want to make sure you do not leave any money on the table. So I got some questions. Who am I talking to? Is this administrators, owners? Well, I'm not going to answer that question yet, but to address that, we're bringing on Israel Rosenberg. Israel Rosenberg of Comprehensive AR Solutions. We're going to have a conversation about that today and discuss the challenges that exist right now. But before we even jump there, you guys know who I am a little bit. Don't know, may not know who Israel is. I'm sure many people do. If you don't mind taking a moment, just letting our listeners or viewers understand how you got to doing what you're doing professionally. How did you get involved in this very, very specific niche part of this industry? And by the way, welcome to the show.
Thank you, Shmuel. Really glad and excited to be on here. Thank you for the warm introduction. So how I got started, doing what I'm doing. My career started actually in this industry, in the accounts receivable and billing industry. I started, my first job was in a thriving company, which was providing something really unique to a client base and owners, operators out there in the world, with solving real problems. The AR industry is an industry that's very complex. A lot of people struggle in this area. And honestly, with my first opportunity that I had in this company, seeing the uniqueness of the service that we provide and the solutions and the problem solving that we were providing to our client base, which were very real problems, and I'm sure we'll get to that in a little bit. So I wanted to take an opportunity to be a bigger part of this company, and to have a higher level involvement in a company that, like I said, is providing a unique service, and problem solving and answering questions and navigating through difficulties, which a lot of people face out there. So that's really the story. Took an opportunity from bottom up, in a company that was already thriving, but wanted to bring it next level and to, like I said, have a high level involvement in this type of company. And that's where I am today, partner and COO at Comprehensive AR Solutions, and it's been a fun ride.
So I will just give first of all, thank you for sharing that.
Pleasure.
I will give a nursing home example from my administrator days. I always loved watching a CNA work their way up to LPN, to RN, to unit manager, to some other MDS, or if it was ADON, DON, regionals, people who really worked their way up the ladder. And it used to bother me when people weren't going down that path. And I realized that not everybody's wired to go that way. But anyone who works their way up for any company from the bottom up has a real deep understanding of the problems that the company solves, how you solve it, and many times is best equipped to change, adjust, grow, just because you have such a strong background within the business.
Yeah, absolutely.
So that's very interesting. So let's move on to this. So the topic of today's conversation is don't leave money on the table. If you are a nursing home operator, counter to popular belief, they're not running around many with tons of extra money and maximizing every single penny that they should be getting. Now let's be very straight and transparent. Healthcare is a business for the most part. There are many nonprofits, but the for-profit industry, many of them provide a very high level of care, and it's a business. They could sell eggs and potatoes. They could open a restaurant. They could drive cars, and they could Uber or Lyft, or they could buy real estate. And they're choosing to make a business out of providing healthcare, and they're entitled to the compensation that's already set for them for providing the care. It's not a freebie that they get. They're spending millions and millions of dollars on that care. What is this? What does that mean? Leaving money on the table? What is this? We're talking about smart operators. How can it be that there's money? And also, can you quantify this problem for us a little bit?
So, first I want to say that I'm jealous of that iHeartRadio mic that you have. Every time I look at you, I get distracted. But um,
I get that
just
all the time.
to pull back on something that you said, because you're excluding non-for-profits from this conversation. We actually have a healthy non-for-profit client base,
Okay.
and non-for-profits need to make payroll too. Non-for-profits need to pay their vendors too. Money doesn't grow on trees. You have to get that money from somewhere, and every business and organization that has employees and that has an overhead needs cash flow, right? They need money coming in, which is again the problem that we're solving. So this is for non-for-profits and for-profits alike.
Okay, fair enough. So tell us, what is the nature of the problem? Obviously, if they provide care, they're going to bill for the care. So tell us a little bit more about the types of payers and how is it possible that we can end up with not collecting money that's due to that's owed to them.
So I want to start by, before we talk about how, just real facts, the industry standard out there, and there's a problem in this industry with collecting on receivables at a high percentage. The industry standard out there is, bad debt ranging from 3 to 5%. And when I say bad debt, I refer to uncollectible receivables, okay? And not just uncollectible, but uncollected, right? We're talking about wrapping up the books at the end of the year. How much am I submitting to submitting as just not collected and dead money? So 3 to 5%, which leaves a big hole in a nursing home operation, right? Let's talk about a facility that's running on average, let's say $8 million a year in revenue, right? So that number can run anywhere from 500,000 to more on bad debt. And when I say bad debt, I'm talking about uncollectible money, right? It's an industry terminology. So we're talking about a reality out there where operators, mid-range operators are leaving hundreds of thousands of dollars a year on the table. So there could be an operation, an operator that's less, 12 million in sales. You could have 30 million, but the percentage is going to be based on whatever your gross sales are. So it's definitely a real problem. How do operators get to that problem? That's a good question. Shmuel, me and you have spoken in the past, and you know that I can sit here and talk probably for 5 hours straight on multiple different scenarios and situations that lead to an uncollectible stay. We'll talk high level, just some basic concepts, right?
Hold on, let me just jump in for a second before we do that. You mentioned earlier about submitting your 3 to 5% bad debt.
Yeah.
What does that mean, submitting it? And is there any type of credit at all that operators get when they do submit their bad debt?
It's a great question. So when I was saying the word submitting, I was talking about more like resigning, right? Resigning to the fact that they have to leave that much money on the table.
Okay.
There is a way for providers to get reimbursed on a small percentage of what they write off, and that's Medicare coinsurance. Okay, so Medicare has a whopper daily coinsurance, which every operator has a hard time collecting on, and no matter how good you are, you're going to have Medicare coinsurance that's left on the table. So Medicare does reimburse. When accountants submit their cost report to Medicare, there is some sort of reimbursement, but that's only a fraction of the write-offs that are out there. When it comes to writing off a managed care claim, or when it comes to writing off an actual Medicare claim, right, where you didn't even get paid from Medicare for the primary, or if somebody who's paying out of pocket as a private pay or Medicaid, there's no way to get reimbursed on that. I mean, you could talk tax breaks depending on how people file their taxes, but there's no way to get money back on what's being submitted as a write-off.
Okay, fair enough. So, fine. I just wanted to clarify that point. That don't think that because there is some reimbursement for bad debt that you shouldn't be aggressively pursuing ways of actually collecting on that debt. Obviously, it's only a small percentage, and we want to turn that 3 or 5% into as close to zero as possible. So now going back to where you were before. So give us some high level scenarios of how such a thing can happen.
So I want to talk about the actual challenges, that occur, and then let's talk about also the management challenges that come along with it, right? Because no matter what you're doing, there's going to be problems, but it's manageable, or is it manageable, right? So there's problems, and there's also issues with managing those problems. So the insurance is a complex world. Every state has its own set of rules and regulations. You have plans that follow federal guidelines. You have plans that follow state guidelines. You have plans that do their own thing with regards to requirements of patient eligibility, how to be eligible for that payer source. You have plans that have their own requirements with regards to how fast you need to file the claim, from the date of service. You have plans that have their own requirements for appealing those claims, right? How much, if there's a denied claim, how much time do I have to appeal that claim? There's various different challenges in an ever-changing industry that's very hard to get a handle on. So, grasping it and having a tight handle on that whole operation is very challenging. And the main problem is that operators are focused on patient care, or they would like to be focused on patient care, right? I know that you entered the wonderful world of staffing, which we'll get to in a little bit.
Okay, let's do that.
Patient care, especially in the times of COVID, right? You have your hands full, making sure that your facility is, you're managing your census properly, your marketing team, your staffing issues, your nursing issues, your clinical issues, your quality of care, your documentation, your MDSs. It's a tremendous operation. And the AR aspect is only one snippet of that, but it requires a lot of management. You have every operator has hundreds and hundreds of lines of outstanding receivables, okay? Every patient in its own payer source, and you could have one patient that has multiple payer sources that are outstanding, right? So you're talking patient by patient, line by line. It's very tedious, very nitty gritty, and very cumbersome to overcome and to manage. And for operators that want to be focused on patient care, managing the AR is simply not something that they have time for. So you have a management problem in terms of, being able to keep a handle on it. And again, like I told you, I can talk, endlessly about some of the specific challenges, but one very, very popular challenge out there, which is something that our organization is a real solution for, and we're really unique in providing the solution, is that billing is a end of stay or an end of month cycle, right? Medicare gets billed at the end of the month. Okay, HMOs get billed at the end of the month. For patients that are Medicaid pending, just to give a brief explanation of what that means, Medicaid pending refers to the time period that a patient is applying for Medicaid. Okay, so most patients who need Medicaid for long-term care don't actually have Medicaid for long-term care in place when they're coming into the facility. Some of them may not have any Medicaid at all. And some of them have Medicaid, but it's only Medicaid for the community, right? They could see doctors, they can, get a hospital visit, but they're not eligible for nursing home long-term care.
Right, but they'll all come in and they'll tell the business office manager, yeah, we have Medicaid standard, of course, no problem. Then you come in, it's like, no, the different
Exactly.
Medicaid.
Or, mom and dad qualifies, right? They're poor. I know that they're poor. There's no money. There's nothing there. Which is, gets into the screening process, which I'll get to in a little bit. But, doing your due diligence to verify the financial information is really important, because there's been so many scenarios where a patient comes into the facility, the responsible party or power of attorney says, sure, mom and dad are eligible. There's 2 bank accounts and combined there's only $1,000. But when you get your hands on those accounts, you see that there was, $50,000 transferred out of one of those accounts 3 months before the patient came into the nursing home, which is a potential disqualifier. And again, Shmuel, I can go on and on. Why is that a potential disqualifier? Is it nationwide? Yes, it is nationwide. But the various things. So, but let's not get sidetracked. The bottom line is that, when if you're just going to be billing and focusing on, getting your claims out properly and even billing timely, you're doing it at the end of the month, or, if a patient's Medicaid pending, you can't bill during that pending process, which could take 3, 6, 9 months. And you can only bill once the patient's approved for Medicaid. So billing by nature is it's a reactive process, right? You're billing at the end of the month or when a patient gets approved for Medicaid. Now, so what could be the problem with such a scenario or such a situation? You're billing Medicare at the end of the month. Patient comes in on April 1st. By the time you get your MDS submitted, you're mid-May. You're only getting your claim response from Medicare 2 weeks later. And Medicare is lightning fast, okay? So we're not even going to talk about HMOs. We'll get to that in a minute. But when I get my denial, potentially from Medicare, I'm talking about 2 months, addressing a denied claim from 2 months after the date of service.
Okay.
So let's talk about what that denial might be. It could be that the patient got denied Medicare because admissions did a great job on verifying the patient's insurance when they came into the facility, but they didn't know that at the last minute, while the patient was still in the hospital, they enrolled in a managed care for the next month. Okay, they ran their insurance, and it was before the patient actually admitted, and there was an enrollment that occurred. So Medicare is now denying the claim because the patient's enrolled in a managed care. So you need
Okay.
to problem solve.
Why? So then, why can't you get reimbursed from the managed care?
Exactly. So you need to problem solve, right? You need to say, okay, is it eligible for managed care reimbursement? Does a patient need to apply for Medicaid? So let's talk about getting reimbursed from the managed care. The managed care requires pre-authorization, right? Almost every contract has that. There needs to be a pre-authorization. Most insurances are not going to go back 2 months and give you an authorization, when you call them 2 months later. As a provider, you need to do your due diligence at the time of stay to make sure that you're crossing your T's and dotting your I's, to ensure that you have an insurance authorization. That's what most of them will tell you. So 9 times out of 10, you're not going to be able to get that retroactive authorization. I shouldn't say 9 times out of 10, but very, very often you won't get them.
Okay.
Medicare, which is like the quickest turnaround time. Let's talk about managed cares, right? Managed care is the same thing. You call them at day 30 and they say, I don't even want to talk to you. The claim is still processing. 30 days later, you get a denial because the patient wasn't authorized for the cost of care, right? You thought you got an authorization. Your admissions team sent it off to your MDS team or your clinical team or whoever it is that's supposed to be maintaining those authorizations, and it simply wasn't there. Again, you're not even talking 2 months back. You're talking 3-4 months back. Okay. So let's talk about, okay, let's work on Medicaid as an alternate solution, right? You can get Medicaid. So again, you're working reactively. Does the patient qualify for Medicaid, right? The patient may have qualified for Medicaid if you would have spent them down timely, but most states have a rule that if they don't qualify for the specific month of the service, you can't go back, right? So let's talk about states that have an asset limit of $2,000, right? The patient can have more than $2,000 in their account. They can have $2,010, okay? And that's going to render them ineligible in many states for the entire course of the stay. So there's real problems with working reactively. Yeah.
Right. No, and I mean that's something that could easily be resolved with taking a haircut in the facility or buying a pack of cigarettes.
Exactly. If you're dealing with it proactively, listen, most of these problems are resolvable, which is why we've successfully been able to collect, 99+% of the AR that we're billing out. And that's because when you work proactively and you solutionize at the time of stay and making sure that you have somebody who has eyes on the patient's payer source, 99% of problems have solutions. I've barely found a problem that didn't have a solution. And again, it's a nationwide audience and every state has their own rules and regulations. Some are more flexible than others, but you can always problem solve. The question is, how soon are you identifying the problem?
Okay, so let me just jump in for a second. First of all, we interrupt this broadcast just to say hi from
LA.
LA.
I didn't realize that. I wasn't sure if that was like a side chat or that's public to everybody.
No, I think everybody.
One of the only Medicaid application softwares out there.
Okay, look at that, and that's probably why he put that there. But moving right along, that was just a little break in the action. But let's just zoom out for a moment. So you're talking about very tedious, very specific, specific tasks that have to happen consistently, and we need to have people to track exactly where each resident is up to at every point, every part of the stay, and even touched on a bunch of specific scenarios where things could have gone wrong and where things do go wrong.
The reactive proactive problem, I think, is the number one problem out there.
Okay. Hold on one second. So let me just get my question out here. My question is like this.
Other problems, but that's the number one problem. Yeah, sure.
Okay. So the question is, nursing home operators are very smart. They know what they're doing. Especially if it's a for-profit, and like you pointed out correctly, so before that, even if they're nonprofit, they still need to deal with all their expenses, and they have to be positive, whatever the word is I'm looking for. But the point is, cash flow positive. Yeah.
So the crux it's at the crux. Yeah.
So the question is like this. This is not. I know that's hundreds of lines of payer sources and residents, and it's tedious, but this is where it's at, right? This is where the business is. Just like you have a P&L for any business, right? You have your profit and loss statement. It's not just another task to do. Like, this is where you put the most attention, and and you build the business around that. A P&L is also reactive, right? A P&L is going to tell you what happened a while ago, which is kind of a similar problem to this. Which, just by the way, parenthetically, there are companies, give a shout out to Megadata, nursing home companies specifically, where they have something called a daily P&L for this reason, so that they can track it in real time. But putting that aside, this should and probably is something that is tracked carefully by many nursing home operators. Do you really, like, when you come into an account that someone's hiring you? Obviously, if they're at 3% bad debt and they want to get to 99% plus, so yeah, obviously that's a lot of money. It's a no-brainer. Do you come in there and find like crazy things? I'll give you one example, and then I'll let you talk.
Yes. I'll get
My
to
first business office manager position, I had zero training, absolutely no idea what my responsibilities were in that role. I came into that office and literally found tens of thousands of dollars worth of checks and just money that wasn't processed all over the desk, on the floor, emails that weren't sent. It was just it was a disaster.
Was it a for-profit group? Was it a for-profit group?
I'm not going to talk about the group, but the point is,
I know it was a for-profit group. So let me ask you a question: how was that? How was that so? Right. That's proving the concept of.
So on that level, I can understand you have a bad employee, and the employee's leaving, so then could be they're leaving for a reason. But on a corporate level, let's say you have a company that has 10 facilities or 15 facilities, 20 facilities. Do you ever come in and find a complete disaster, or are you in the business of fine tuning?
Some and some. I've seen complete disasters.
All right, tell us about your worst disaster, if you're allowed to, with hiding the identifying information. Okay, worst is going to get your mind thinking because you want to know worst, and second to worst, a bad case, an exciting, fun case.
Let's talk about global, right? General. Okay.
No, he's not allowed to say a specific case.
I want to answer your question. Nursing home operators are smart for the most part. And many of them do have a tight handle on many aspects of their business. The billing world is very tedious, like I mentioned, and it's very easy to get suckered into excuses. Let me paint you an example of something that I see all the time. So you have a patient who, the scenario that I just told you, okay? You have a patient who came in as Medicare, but really enrolled in a managed care. I mean, what do you do to mitigate such a problem? Do you really want the nursing home operator, who's very sharp, to run every single insurance verification and do mid-stay verifications while the patient's in the building? I mean, it's simply not something that's feasible, not something that they have the manpower for. Or something that, I spoke about excuses before. Let me just put it this way. Medicaid eligibility in many states takes a months-long training to understand the nuances and what Medicaid requires, what the obligations are, how the caseworkers are on the Medicaid end, processing the cases, how they process the cases, what they like to see on their cases, which nobody has time to learn, right? A nursing home operator doesn't have time to learn about the specific nuances. So the result of that could be, uneducated staff or staff that are not performing at a high level. They're not crossing their T's and dotting their I's. So, for example, Medicaid application was submitted with the full amount of bank statements that was requested. Okay. Somebody didn't look at them. Somebody didn't look at the bank statements, and there was a transaction which linked to another account that somebody missed. Okay. That other account, showed a full-blown bank account, which, by the way, didn't have any money in it, but there was an income source going into the account every single month, and somebody was taking that money. Medicaid, believe it or not, even though Medicaid is for poor people, right? Medicaid has a copay, which is, every state has their own terminology for it. Some define it as NAMI in New York, patient liability, client participation. Basically, patients are obligated to pay their income towards their cost of care. Right. And if you're looking at a Medicaid case, and not identifying every single source of income that's there, then you can have a patient who's in your facility not paying that bill until Medicaid identifies it for you 6 months later. Have fun trying to go ahead and collect it. So the tediousness and the complexities and the far-ranging rules is the answer to your question in terms of it's simply put a really hard industry to get a handle on it. And by the way, the scenarios that I'm detailing is something that every single operator hears and knows about. Oftentimes they feel like there is no solution to it. Like, what could I have done better? But there are solutions to it, and there are ways of identifying things and being very proactive on every single patient stay. And every operator or CFO can relate to the scenarios that I'm talking about. Oh yeah, I've heard that. I've had problems with that. Our smartest, I shouldn't say our smartest client, because all our clients are smart. But some people are micromanagers on micromanagers on various different levels.
Okay.
We've had people who were type micromanagers who were being sold answers by their Medicaid coordinator or their business office that they had no idea how to identify if it was true or not. Right? They tell you the insurance changed their rule after I sent a claim, and that's why the claim got denied. How you gonna know if that's true or not? Right? UBs, which
I'll
is
tell you, hold on. I'll tell you how you know that. Because if you become a nursing home operator, because you started out in the business office and then you went up, you became an administrator, became a regional, and then you became a partner in a nursing home, like you did in your business, and like the CNA we described at the beginning of this conversation, then you're gonna know that this guy is pulling the wool over you.
yeah,
If
I
you
know.
came in,
It's an ever-changing industry. I mean, we've drastic. I mean, I'm in the company for 8 years, and there's drastic changes that we've implemented company-wide because Medicaid is an ever-changing industry. Some states decide to go managed care, right? We're going to do away with Medicaid and we're going to go managed care, which comes with a whole set of new requirements for the billing team, right? So it's an ever-changing industry. There's a lot of moving parts. Things are changing. Medicare used to have qualifying hospital stays. They don't have qualifying hospital stays anymore. And by the way, there's talk about eliminating that entirely, not just during the pandemic. But things are changing.
for one thing, you're talking about for Medicare.
Medicare, yeah.
Why would they do that?
Why would they eliminate the 3-day hospital stays?
Yeah.
Because if a patient needs skilled nursing care, why should they be required to sit in a hospital for 3 days before that? I mean, you have so many hospitals that are literally, ready for discharge, and they're literally keeping patients in a hospital for that third night so that they can cross the T and say, okay, patient was here for 3 days.
Okay, so really, this is an old problem.
Whole different conversation.
Right. I mean, but it's indicative that the rule maybe never really made sense to begin with, and just now that we had the opportunity to do away with it, we're like, let's do away with it.
It's like with many things. It's like with many things. Like, who's looking at every piece of of legislation that's out there, right? It's been created over years and years of high level decisions that were made based on what made sense then. But like I said, it's an ever changing industry. There's so many moving parts. So if you were in the industry and a business office manager, Shmuel, I don't know how many years ago you stepped into that business office, but let's say it was 7 years ago. It's a whole new world today, and I guarantee you that you'd fail on your first day back because of all the changes that happen. So you can have somebody that's very familiar, but not familiar with the changes that are being made. And by the way, how many operators do we see that had their experience in New York and then bought facilities in Nebraska or Texas? Every state really has their own unique way of operating on the billing side, on the Medicaid application side. So that's why you need an expert in that specific area, somebody who's following the trends to be able to identify, implement, and plan processes to mitigate those issues and those changes.
Okay, so here's a question. So you have an operator, they understand everything that you're saying. They tried their best to do what they're going to do, and they know that some of these answers are incorrect, and they don't deal with it. What's going to happen with them? What's wrong if they leave things the way they are?
Who doesn't want to collect on everything that they've provided services for? I mean, if you ask any operator out there, I mean, do you want to know that whether or not they'll go under if they're not addressing the problems? Some and some. I mean, we've stepped into clients that were on the verge of going under, if not for the fact that we came in, collected a lot of old money and made changes moving forward. But even if not, right, if an operator is profitable and they're able to.
Yeah, well, hold on. We got to stop right there. So if I'm not even talking specifically about your company, but it's a very, very difficult industry all right, the profit margins are slim to begin with, right? It's very, very expensive to provide good care.
Mhm.
And like you said in the beginning, many operators go and their intention is to provide very high level of care, and their heart is in the right place, and they really go the extra mile to provide the care. But then they find out that not just not profitable, they're not breaking even, they're losing money year over year. And like you said, they could be at the verge of saying, this is not working, we got to close up shop, or we got to bring someone else in here who can figure out how to do this for a profit. And just by doing this properly, we're not talking about collecting versus not collecting. We're talking about someone who's doing a good job and getting 97% of
Mhm.
their collectibles. But if now they get 99% of their collections, that could be the difference between staying in business and being profitable. This could be the whole profit margin right here. So,
Absolutely.
so, so that's a pretty powerful statement. So, doing the difference between good and great as far as your collections could be the difference between survival and profitability. And so, which is fantastic. So, what are some things that a nursing home operators can do today in house that might be able to help them somewhat, and maybe even give us just like one or two things that might be able to do to help them with this process? Something they can implement right away.
So I think that to touch on a point that we've spoken about in the past, which is so common, every single billing team has to have a incorporated into a organization or facilities billing team. There has to be a team or individual that's dedicated on watching the patient from the point of admission to discharge, making sure that you're working proactively. Okay, and we could talk about, there's a lot of different aspects that go into it, right? Because every payer source has their own requirement. So what do I do on a Medicare patient to make sure that I'm watching it proactively? What do I do on an HMO patient? So there's, obviously we're not going to get into that because every payer source specifically has its own answers, but you need to incorporate in your billing team a team that's watching patient stays on a proactive basis, so that you're not falling victim to being reactive. um,
Okay.
and by the way, that's just it's a staffing thing, right? It's about making sure I shouldn't say staffing thing, because I'm going to get to the staffing discussion in a minute, but it's a manpower thing. People underestimate the manpower that's necessary to have a high level operation, and this is something that's absolutely key. If you don't have a proactive person, you will fail inevitably, and it's not maybe you'll fail, you will fail. There is an absolute need to watch something on a proactive basis and not just work reactively.
So this is not something to just add to a receptionist that between phone calls to try to look through a spreadsheet and
Correct.
try. This is something that requires. So it sounds like it requires two things. This has to be like a priority, a focus for whoever it is that's tracking the patients, and there's also they have to have some level of competence with the Medicaid, Medicare, managed care of how reimbursement works and what are the things that are important today that will affect reimbursement down the road, because we know that the payment may not come for 60, 90 days. But right now, me filling out this form right now with insurance and getting that prior authorization or sending the update in a timely, manner, and even just developing relationships, with the case managers at the insurance companies, these are things that are critical to the success of fully collecting on the care that we deliver, the fantastic care. So you're saying personnel, just having someone dedicated to this, yeah, obviously that is key. What does that person really need to be the expert in all of these things?
Yes, because you have every payer source walking through the door on every single facility out there, right? So you need to be watching Medicare's, HMOs, Medicaid, patient portion, patient liability, private pay. You need to be experienced and knowledgeable and proficient in
Right,
the rules and regulations that apply to each payer source.
right. I mean,
And
if this
by the
one,
way, it's not just having a body, it's also having a body it's really having a bridge, right? Making sure that it's somebody that's incorporated into your billing team. A lot of facilities may have somebody, but they're not collaborating with their billing department. It's one team.
got it, got it. I mean, you can probably have less experienced, less skilled people who are doing the basic tracking, and then you can have some people who understand what that means. As one person will report that now this person's managed care may have no idea what that means, but as long as they're in touch with the rest of the team, who knows? Okay, now do the following steps. That might be able to work to some extent.
Right, and I also want to touch on another point, right? How operators can help themselves. Um, Again, staffing and making sure that you're adequately staffed. And I spoke about proactive and not reactive, but let's forget the proactive, the proactive department. Okay, even on the billing side, right? With the amount, and I keep on saying this, but it's so true that the amount of staff that's needed to properly bill for a facility at a high level is really, really underestimated, right? So I think that, when it comes to CNAs or nursing or admissions departments or, social work departments, there is a universal accepted staffing requirement that people understand.
Okay.
So you know what you need to staff for, and now you have a staffing problem, right? So by the way, reach out to Schmoll's Optimist because he can help you with that. But
That is very
the,
true.
the first the first thing is recognizing if you have a staffing problem, right? You can only staff properly, or at least attempt to staff properly, if you know that you have a problem. In the billing world, one of the challenges that we see is that people underestimate the amount of manpower that's needed. If you have one biller, okay, who's tasked with making sure that all pay resources are collected, does that person have time to spend an hour on the phone with an insurance company fighting a claim, okay, I don't know, 12 hours a week, yet also make sure that her UBO4s and her claims have every single line item checked off properly on the UBs, right? Because for example, you can have an insurance authorization. Okay, many insurance companies require that insurance authorizations be listed on the claim. If you have one digit off, you can have a denied claim. So do you have, and it all comes down to being diligent and having ample time to do what you need to do, right? You don't want to have a cash flow problem. You don't want to send out an insurance claim and then get denied. You want to be able to work on the front end. So do you have enough time and staff hours allocated to the tedious task of making sure that everything is billed properly, being on top of the research in terms of rules and regulations that are changing within the insurance companies, because an insurance company can say from one day to the next, by the way, I need this thing in line item number 4, which I didn't previously require. So it comes down to just being diligent and having the proper amount of people, and I think that's something that's very, very underestimated in this industry. And I think that providers need to take a hard look at, okay, how much time am I allocating to my facility? And we can help with that, just on a consulting basis. How much time do I need to allocate towards my facility? And do I have enough manpower, right? If my biller goes out on sick leave, does she have enough time to make sure that she's backpedaling fast enough to not miss any timely filing, in addition to maintaining the current caseload of the ongoing weekly or monthly billing? And that's something that's a problem, which can be solved if you're identifying your staffing needs properly.
Okay, so that's a very valuable point. So if operators saying, "Oh, I'll do it in house," I'm like, "Okay, great, knock yourself out, do it in house, be successful at doing it in house," but realize, this is what it's going to take. So now, if an operator realizes that they don't have the manpower and they can't afford the manpower to do this process, and they want to bring in comprehensive AR solutions, how do you interface with the facility, and what type of immediate relief are they going to see?
Depending on the scope of depending, to answer the what type of immediate relief, right? Depending on the scope of the issues that the facility is facing, and depending on the facility size, it can be immediate. First month of our service, we're making sure that the claims are billed timely, properly, adequately, making sure that every single patient in your facility is Medicaid eligible if they're Medicaid pending, or it can be a process of a couple of months. If it's a really big facility that has real surgery that needs to be done. Now, in terms of the integration and how we interface, it's a great question. So we have multiple teams within our company. We have the front-facing, client-facing integration team and transitions team that's working on the facility level to make sure that from day one, there's constant communication with every team that relates to AR on process changes that need to be made. And that's seamless as long as we have operations support on making those changes, right? Which is what, assuming they want, because they want to be successful. So we have an implementation team that works with that. And we have a billing team that's working on the back end. But there's a lot of changes. More often than not, we're making a lot of changes within the facility, and we have a team for that. Client visits, facility visits, whether it's at the facility location, a corporate back office, whatever it may be. Multiple visits, by the way, to ensure that processes are being changed, because that's what it's all about. It's about having healthy processes in place. Once you put healthy processes in place, then you're integrated and things are working almost automatically.
Wow. So interesting. So you come into a facility which is really suffering, and they know that they're leaving a lot on the table, and then you come and you help them set up their processes. So are you making them hire more employees, or are you helping them changing what they're currently doing?
More often than not, it's about changing and restructuring and making sure that there's clear understanding of who does what. A lot of times you walk in and there's an admissions person that's also doing business office functions, or a social work person that's also doing business office functions, or a business person that's doing admissions functions. Lines are blurred, lines are not clear. And as a result, people aren't producing at a high level. So coming in and creating very clear operational structures is a big part of our service and a big part of what we do. We do find sometimes that people are, facilities may be short-staffed. I would say it hardly ever happens. Usually there's the ample manpower in place. It's just about number one, introducing processes, which facilities didn't previously know about, but also making sure that lines are very clear. If you have blurred lines, and this is really anywhere, right? If lines are blurred, then people can't do their jobs, whether it's within our organization, your company that you do, facility level. The roles need to be clearly defined, and that's something that we really help out with.
Wow. So it sounds like it would be that itself is a tremendous value. Okay, I just see that we were having too much fun here in this conversation, and we went way over the time that we usually do. Any final words that you would
go on all day? I'm not ready for
it. Any final thoughts you would want to leave with our listeners and with our viewers about it's really fascinating. But about this part, you would think that this is collecting your money, right? It's like not having a cashier at the supermarket.
Yeah, you have no idea how many people, there's so many people don't want to recognize that they're failing, right? So many people don't want to admit that they're failing. And that's a big part of it is coming to understanding and accepting the fact that it can be better. And let's face it, people are also scared of outsourcing. Especially AR. It's such a core part of their operation, right? But we have a good team. We work together with ownership, CFOs, administrators, CEOs, whatever it may be. And the risk reward is a no-brainer. So that's kind of
right. So I'll tell you like this. Outsourcing, there are many different parts, like you said in the beginning, and you said it very well. The nursing home business is a very complex business, and it's true. And there's so many different businesses within the nursing home business, and compared to other settings, I'm referring specifically to like the acute care settings, they're doing it with very, very limited resources. So they're a full service hotel, right? Maybe without the swimming pool, and that might not be the case across the board. But plus the therapy department itself is its own business. The activity department is its own business. You have maintenance, you have housekeeping. There's a business office, obviously. And it's also happens to be a mini hospital, right? They say the community hospital of yesterday is the nursing home of today. So there's so much more that's being done now in nursing homes that they were only done in a hospital setting. So it is really complex. And if someone's doing it, and I would say, tell me if I'm wrong, that someone who is profitable and they are making money and they're happy with that, and you're going to come in and say, oh, you can make more money. So you might think as an outsider, great, show me how I can make more money. I want more money. But no, if I'm already profitable, then, I kind of think I know what I'm doing. If someone's teetering on and their business is collapsing, I assume they would be a little bit more open to some outside assistance. Is that true?
Yeah, that's true. That is true. Some people are some people by nature only make decisions when they're, at the edge of the cliff and almost being pushed over. There definitely are many clients that we've onboarded, that were in those type of situations. But everyone wants to do better. Everyone wants to collect at a high level, right? Even if somebody's profitable and they're doing well, who wouldn't want an extra 2%?
Yeah, 100%. Well, listen, Israel,
It's
thank
black
you.
and white. It's black and white.
What?
And it's black and white, right? It's not like
There's no ambiguity when it comes to numbers.
it's exactly. It's where you at. Where you at. If you're doing a great job, then fine. You don't need any help. But if you're not, it's very clear. So just wanted to leave off that. People listening out there can feel free to visit our website, www.comphcs.com. Okay, COMPHCS.com. Shoot me an email, israelr@comphcs.com, ISRAELR@comphcs.com. They can call our toll-free number, 877-942-4558. And there are many ways that we can assist, whether it's full scope of revenue cycle management, collection services, if you don't want to outsource your entire thing, but you have, challenges collecting some aged balances due to change in turnover in your department or whatever it may be, we can do collection services too. It doesn't have to be a full outsource. We can assist with Medicaid applications. We have a Medicaid application division. We have a contracting and collections division, which, by the way, we didn't even get to talk about that, Shmuel. Maybe for another time.
Okay, we might have to.
We really have a full suite of AR services. AR related services is what we're built for and what we can provide to our client base.
Okay, it looks like some people really like you.
Sandy Shore, Israel Rosenberg, Michael Hirsch, the best team in the business. I second that.
Who's that from? Oh, Morty. Thanks for chiming in. Okay. Yeah. One question I'm curious with, before we let you off the hook.
Sure.
Are there nursing home operators today that are collecting at 99% plus without any outside assistance?
I'd be foolish to say no. Have I seen that? I don't think so, but I'd be a fool to say no because I don't know everyone's operation. And I'm not one that's on a high horse to say that, we do a job that nobody else can ever do. I'm sure there are people out there that are operating at a very high level, even the AR industry, whether it's, they have it outsourced or whether it's a really tight team with AR knowledge that they put into place. I'd be a fool to say that it just doesn't exist. Most of the agings and AR that I've seen from whether it's existing clients or potential clients are most of them not even, I should say all of them, are any of them at 99% before our services? The answer is no, to be honest with you. But I'd be a fool to say that it just doesn't exist, right? Maybe I just
got it. Okay, listen, thank you very much, Israel, for coming on the Nursing Home Podcast.
Thank you.
This is a topic that we haven't really gone into before. So I really appreciate the information that you've shared, and I could see that it was very informative. And it really was, because also I'll even speak as an administrator for a second. A lot of administrators don't really get to fully understand this process. They just get harassed by like a regional when a biller can't get through to the business office manager, and all they know is that they have to connect the dots and make sure that they're talking to each other without fully understanding how this really impacts the bottom line. So you really give us a very good picture of how the system works as a whole, and then coming in and each person, whether you're the administrator, whether you're the admissions coordinator, the marketer, anyone along the road, I'm talking internally, anyone in the process, you can understand how what you're doing directly impacts the bottom line and the success of the overall organization. So I mean, for me, that was extremely beneficial. But either way, this episode is live now already on LinkedIn and on Facebook, but it will be live at the nursinghomepodcast.com. All of the information, the links, the phone numbers, everything will be available in the show notes as well. Thank you very much for joining us today on the Nursing Home Podcast.
Thank you for having me, Shmuel. One last ask. Can I get a iHeartRadio little mic? That's all I
want. You definitely can. You can have mine here. See if I can figure out how to take this off, and I'll give it right to you.
All right. Thank you so much. Thank you for having me, Shmuel.